tweet us on KTN Kenya, or you can tweet me directly and we'll see what we can do about that. Today, we'd like to focus on community health workers, their role, and of course, we do know that one of the agendas that the government has is achieving universal health coverage, and it is not possible without community health workers. But what exactly is their role? Where do they come in? Where does one become a community health worker? Are they remunerated? How do they function? That's a discussion we'd like to have. And joining me in studio, I am joined to my extreme left by Professor Miriam Were. Thank you for joining us. And also Margaret Kilonzo, who's a community health worker right here in Kenya. Thank you for joining us.
Thank you.
So let's start with a very basic definition of a community health worker. And I'll ask you, Margaret, because you're one, what is your job description?
Okay, thank you very much. I'm Margaret Kilonzo, a community health volunteer from Kibera, who was trained by HAMREF.
And I see a change there, from worker to volunteer.
Yes.
Okay, I think that's crucial. Okay, carry on.
Yes, we are volunteers.
I picked that, okay.
Yeah. Mm-hmm. And we are volunteers because we are not paid.
Okay.
Yeah, we are just volunteering.
So now, when you're working or volunteering as a community health worker, what does your job entail?
Okay. After we were trained by HAMREF, in collaboration with the Minister of Health, we were allocated households, whereby, like me, I have 500 household members whom I have to take care of. Mm-hmm. In these households, we do education, preventive issues. We focus most on preventive because we don't want these people to be sick. And as a CHV, I act as the link between the community members and the health facility.
Okay.
So when we go to these homesteads, what we do, one, we identify any problem. We do the photo tracing, follow-ups. We address issues of stigma and discrimination. Mm-hmm. We also do screening, especially for NCDs. And whatever we do in these households, we document everything. Mm-hmm. Then we submit to our CHUs. CHUs are our supervisors.
Okay.
Then after 3 months, we hold dialogue days, mm-hmm, where we discuss the data for 3 months. Then in case there is issue, let's say, for example, we find that, let's say something like diarrhea is increasing, we plan for an action day. Mm-hmm. In these dialogue days, we involve all the stakeholders.
Okay, I'll come back to you on maybe the findings that you have found through your work and maybe how long you have worked. But let me come to Professor Were and maybe just give us your thoughts as a medical doctor on the importance of a community health volunteer.
Thank you very much. We appreciate this opportunity to talk about community health workers. I was happy to note that you introduced the topic by saying universal health coverage, and that we cannot get there without community health workers. That is an issue that seems to be increasingly misunderstood in this country, in the sense that when you hear about universal health coverage, you hear governors or other leaders saying things like, each family should pay so much, get a card, and go to the hospital, and you will get any medicine. Now, that is putting the cart before the horse. And in saying so, it is assumed that when you go to the hospital, you'll get services there. But last week, the newspapers, both our major newspapers of the country this last week, were pointing out that there are people get to the hospitals and they don't get any supplies there. There are no medicines. There are no this. So there is a misunderstanding on universal health coverage. It does not mean going to the hospital. It means improving the health of the people. And this is where the community health services come in. And in the community health services, the community health worker is kingpin. That is the kingpin of the community health service. Because you organize, you mobilize communities to help look after their own health. And in this case, you are helping them to promote health through improved nutrition, improved hygiene, improved latrine use, and they promote their own health and they prevent disease. So the issue of promoting health and preventing disease are very key in community health services. And then finally you have first-line curative services so that they don't get to the... So the whole point of community health services is to decongest health facilities so that the health facilities are not dealing with the diarrhea and vomiting and so on, which tend to congest health facilities.
And which can be dealt with at the very basic
Yes,
level.
they can be prevented first of all, and then secondly, they can be dealt with that. But now we keep on pointing to the fact that universal health coverage means everybody going to the hospital, which is a very basic misunderstanding, and we shall not make it if we go that route.
If we go that direction.
Yes.
Let me come back to you, Margaret, and Professor puts it rightly that the hospital is more or less the back end. It's where you go when all these other things have failed, where you've not taken care, when it's something that regards care. But what are your findings? You've mentioned that you have, is it 500 individuals or households?
Household members.
Household members. So
Yes.
that could be over 1,000 if each household has 2.
No, there is a difference between household and the structure. I have 100 structures with a population of more than 500 people inside.
Okay.
Yeah.
So you take care of at least, what are your findings through and how long have you been a community health volunteer?
I've been a community health worker for 20 years now.
For 20 years.
Yeah.
Now, give us your findings in regards to what she has said, that we concentrate a lot on the hospital, whereas there is the preventative, that is what you concentrate on, and education. There's also the element of just people having information.
Okay. What I can say first, before the intervention of AMREF, people used to be very sick. We didn't have any knowledge because in the community there were no CHVs. Then when AMREF came, we were trained on how to handle things in the community. And before then, there was a lot of maternal death. There was a lot of poor sanitation. Children were not finishing the immunizations. All kinds of diseases were there. But after the intervention of AMREF, we were trained on how to deal with these issues. And if you can compare before they came and now, there is a lot of improvement. In fact, AMREF have helped us so much because even trainings, they have trained us on mobile technology as for now. Because now we are collecting data through the mobile phones. We are getting education through the mobile phones. And that is a plus to AMREF. And if you go to the community right now and you compare the way it was before AMREF came, there is a very big change. These community have been empowered. They know the importance of hand washing. They know the importance of attending pregnant mothers to attend clinic in time. Children are getting the immunization because now it is very rare to find a woman who is giving birth into the house. It's very rare to find a child who is not.
And that is down to the information that you have given them and opening up their minds to the fact that there are risks,
Yes.
there are dangers, and vis-a-vis the
Yes.
advantage of doing this in hospitals.
Yes.
Okay. And from your observation, once you have dealt with the community level information, are the hospitals able and do they have the capacity to now take over what has gone beyond the community?
Yes, let's say for example, if we get cases which we can't handle, we have to refer. And we make sure it is a complete referral, whereby we make sure they reach and they give us the feedback, or we escort them to the clinic. And when we go to the clinic, they are assisted.
Okay.
Yeah.
Professor, let me come to you on the importance of preventative as opposed to curative measures, which is what they're concentrating on.
Yeah.
And this is just sometimes basic information, nutrition, hygiene, the water that we use, things
Yes.
that we do every single day that could help us to be
Yes.
healthier. We don't have to get to hospital.
That's right. And that is the point that universal health coverage emphasizes on, that we should be preventing, we should be promoting health, and we should be providing first-line health care so that people don't. The whole point is that, Africa, sub-Saharan Africa, we are only 10% of the world's population, but our disease burden is more than
It's huge.
25%. And sometimes with specific to certain diseases like HIV/AIDS, we are even more than 70% of the world. So we have a very high disease burden. You cannot reduce the disease burden by focusing on hospitals. You have to reduce the disease burden by focusing on promoting the health of the people so that you have a healthy population. And to do this, you have to get to the community level and change community norms. And this is where the community health workers are so key, because you have to change the community norms to move them towards health promotive and disease prevention. Now, this is where it becomes an abuse of the human rights of the community health workers to make them volunteers. Because volunteers means they are not paid. Now, what you have heard from Margaret means that she works every day Now, if she's a volunteer, which means nobody's paying her anything,
For
how
what
does
she's
she
doing.
buy her dress? How does she's also a mother. I know her, so I know she's a mother. How does she feed her children? How does she get them to school? So the whole idea that Kenya introduced, the idea of community health volunteers, is actually an abuse of the human rights of the community health workers. Because when I was doing the basic research on community health in the 1970s, the people themselves said, if we are going to have community health workers, we must pay them. And people used to have household levies so that they put it together. They had established community banks, community health accounts, so that they could pay their community health workers. So what we are saying as part of UHC, the government of Kenya, and AMREF is advocating this throughout the continent, must have community health workers as paid within the community, the health infrastructure among the community health workers, not volunteers.
Not volunteers.
They are workers. You cannot make a volunteer accountable. And when Margaret is very exceptional because she has stuck with this job for 20 years. But many volunteers, they drop off, of course, when they have nothing to eat, they drop off, they look for other things.
Or if they find something else to do that is paying them.
Yeah, so you can't keep them.
All
so
right.
you can't really meet your targets. To meet your targets, you must have people on the payroll. And AMREF has made this point very clearly, to the point that, of course, in Ethiopia they are paid. They are fully paid on the payroll. And Ethiopia is a much bigger country. They have more than 30,000, 40,000 community health workers, and they are paying each of them. They call them health extension workers because they are using the terminology from the agriculture sector, agriculture extension workers, and they just said health extension workers, which is a very good concept also. And they pay them. Rwanda pays them. Even Sierra Leone is paying them. And we in Kenya must think in terms of how do we
do that?
Include the community health worker within between the health workforce framework.
All right, and let me come to you, Margaret. How do you get by? I mean, there are very many people who would wonder how you manage to do that on a voluntary capacity. And like she mentions, like Prof mentions, you have needs yourself that you need to take care of.
Okay, to add on what Madam has said, remember we are family members. We have to balance between the family and the work in the community. Because we have that passion of helping the community, we don't want to leave them behind. But the problem is that we are not paid.
So how do you get by?
Now, the problem is most of us, we are beggars. Because we go to organization to beg them to give us jobs, others pay us, others they don't pay, just like that. And we have to balance. Then after that, you go and do casual jobs. Maybe in the morning you do the community work, in the afternoon you go to do casual works, whichever you will get.
Just to get by and to
yes.
make an extra coin.
Yes.
All right. And given that you play such a huge role, what do you think is the reason that community health volunteers have not been changed to workers who are paid, who are on the payroll?
That is why we want to know. Because they are doing a lot of job. Because let me tell you one thing, nobody knows the community very well except the community health volunteers. And they have that bonding with the community people. So I don't know the reason why the government is not paying us.
Professor, is there a reason that we know why they're not being paid?
Well,
I mean, it's a critical role they're playing.
I think there was this misunderstanding from the beginning that community level is sort of dismissible. And as an expression of dismissing that, it seemed like, okay, they're just volunteers. They are not really health workers. Nurses are professional. Doctors are professional. I can tell you, I'm a medical doctor. And I have taught in the medical school in the University of Nairobi for many years. But I can tell you that the effect of the community health worker is critical for the health of the nation. And, you know, if I may just be a little bit blunt, I have talked to some of the community health workers, and they whisper in my ear, Mama, you know, we have sometimes to sell our bodies to get by. Because we have nothing else. What can we do? So you see, we are pushing them into immoral living. And that is something that people don't think about. How do you manage to actually get by? You have children, you have yourself, you need to look neat, you can't look after people. I visited some community health workers in Thika sometime last year, and who work with an organization called Living Goods. And they told me, you know, even the word community health volunteer makes the community not respect us. Sometimes they just say, you're just volunteers. So they dismiss us. So they told me, why don't you even give us another name, like health promoters, like health, well, why should we use all those other names when they are just health workers? So really what AMREF is advocating, and what is completely in line with the work I have done for more than 50 years, is that we should have community health workers within the community, within the health resources framework, budgeted for, paid for, accountable, and held up to targets. And you know, in Kenya, a community health worker is responsible, according to the formal definition. Every sub-location has one community health worker. So there are not that many.
Of course, and maybe part of the reason why there are not that many is because they cannot get by. They can't. They're not being paid.
Yes.
Margaret, what do you see as the way forward? You've done this for 20 years. I'm sure there have been groups that have probably come up to try and advocate for community health volunteers to be turned into workers by being paid. What do you see as a way forward?
In fact, AMREF has done a lot for us. It has been advocating for our pay for a long time. But I think what could be done, they should recognize our job and pay us.
When
the
you
government.
say they, who? The government?
The government.
Okay.
Yeah. Because I don't know, they know we are working and we are doing a lot in the community. I wish they could be like AMREF, which have seen our job and they know the importance of what we are doing. And agree to pay us.
All right. Prof, is there a structure that possibly can be proposed for them to be paid? Because then if it is a government worker, they have cadres, they have different job descriptions. Where would a community health worker fall under?
Well, you know, in the government, we have got office assistants, we have got drivers levels, we have got all these levels. So the government can find a place where to fit them, so that the community health workers are in the line. They can be like the same level as office assistants or some level. We are not saying that they must be paid huge sums of money, but we are saying that you should be paid at least the minimum amount accepted by the public service, so that they also have dignity. We would like them to live a life of dignity because they are contributing a lot to the community and to the nation. And you know, people will tell you, oh, but there is no money. But you know the way money is misused in this country. You know about the stories of our stories.
The money is seemingly there, but in people's pockets, which is unfortunate.
I mean, I always say, for instance, even if we have reduced the number of public cars, or make them a bit cheaper rather than having the petrol guzzlers for the public servants.
So be it.
If we are serious about the work that they do, we shall find ways of making funds available to pay community health workers, because they are very key, especially in the President's Big Four agenda of UHC as one of the key issues. We must find a way to support, to pay community health workers so that we can succeed. And you know, if you succeed in health, you succeed in everything else. Ethiopia found that the reason they paid so much attention to health is because they found that if you have a healthy population, you also have healthy farmers, and you have better productivity, you have healthy road workers, and they do a much better job. In other words, you improve the health of everybody, which is what Vision 2030 in Kenya says, a healthy population to make us productive. But when you have an unhealthy population, because of this approach that we are using, focusing on a facility, go to the hospital does not reduce disease. So
absolutely. All right, so let me come to you, Margaret. And AMREF launched a campaign on creating awareness on community health workers, which is why we're even having this discussion. Yeah. What is the main objective that AMREF have as they have launched that?
I think they are aiming to see that the CVs are paid. I think so.
Bottom line, that you are paid. Yeah. What about training? What sort of training do you go through?
A lot of training. Those were conducted by AMREF.
AMREF or government, or whichever quarters that you get your training from?
We usually get our trainings from AMREF in collaboration with the Minister of Health. Yeah. And they have trained us on all issues concerning health. Yeah.
There is a program for training which is approved by the Ministry of Health. AMREF carries out some of it, and the Ministry of Health carries out some of it. And the point is that what AMREF is advocating is what they call strong community health worker programs across Africa. Strong community health worker programs as the way to what UHC in Africa. We had a conference in last month in March in Rwanda. The whole of Africa came together to discuss how to establish strong community health worker programs. And the point is that we must have a curriculum. Well, first of all, we must have a policy, the community health worker system must be recognized within the Civil Service Public Service Commission. It must be established within the framework of the job descriptions and the payments within the Ministry of Health structure. It must be recognized in terms of an approved training program, and it must be recognized in terms of the accountability of the community health worker.
The community health workers.
So that there are all these facets, the public policy, the payment, the training, and the accountability, so that community health workers are also held accountable. And we have such a high dropout rate. In some countries, it is 70%. After spending money training them, 70% drop out.
And what's the reason for their dropping out?
Because they have nothing to eat. It's basic. They have no food.
It's mainly remuneration.
Remuneration.
Right. Margaret, what would your plea to the government be if you had an opportunity to speak to the stakeholders and those who are decision makers? What would you tell them?
Now I could tell them like this. Nobody understands the community very well more than the CHVs. So they should know what they are doing, of which I'm very sure they know. And they should pay these people. These people have needs like any other person. Sometimes we have challenges, which they really know. Imagine like now, we are going to the community, telling people to register for NHIF, yet the CHV doesn't have. You know, that is a very big
no income, yes.
Yes, because he or she can't pay. So I'm pleading to them, please to pay the CHVs so that, in fact, they can live a decent life like any other person. Yeah, because they are family people and they have to provide for their families.
Prof, what would you tell government stakeholders and those who make decisions if you had the opportunity?
Government stakeholders, I would tell them that, you know, when government workers go to the field, even just to visit the field, we get allowances, daily subsistence allowances. Now, how can we be comfortable with people not getting any payment when we also get our salaries and travel and per diem allowances and so on? That is one point. The second point is simply that we shall not succeed unless we reduce the dropout rate of community health workers. Because we must, and they are dropping out because they have no way of supporting themselves. So we spend a lot of money on training and then they drop out. So what is the use? It's a dead-end approach. And what I'm saying is that really, when you come to the basics of it, it's a human rights thing. We are abusing their human rights by saying, I mean, when we say people should get jobs, we are implying that people should be remunerated.
Right.
For instance, Ghana decided that one way of dealing with youth unemployment is to make community health workers, those who have just finished high school, as a means of creating jobs. Of course, they pay them. You can't give a job, you can't say, I'm going to give you employment and then give nothing. So the whole terminology of community health volunteers, I was very sad when it was introduced in this country. And some countries have borrowed it from us. But it is an abuse
of their rights.
Of their rights and undermining our own achievement in universal health coverage. And you know, there is a very focused approach of saying that we should have a package of services, a package of supplies, a package. The people think that universal health coverage is having a package of supplies. And that's what they hope the hospitals will have. But they don't.
They don't.
Let's
Margaret,
disease
what are some of the success stories that you have from community health work that you have done? You've done it for 20 years. That's a long time.
Yes. As I told you before the intervention of AMREF, there was a lot of maternal death. There was poor sanitation. Children never finished their immunizations. There was a lot of issues concerning health. But when we were trained by HAMREF, if you go to the community right now, it is very rare to find a woman giving birth in the house or to the TBA, traditional birth attendant. Also, the children under 5 are getting their full immunizations. Sanitation has improved, and the community members have gotten the knowledge whereby we have addressed issues of stigma. You find that we have started support groups where we address issues of stigma. It is very rare to find somebody who's bedridden in the house. Nowadays they are taking drugs as they are recommended to do. I think we have done a lot.
You've done a lot. All right.
Yes.
And actually, when you go to the communities where there's a community health worker active, I was in Migori some time ago, and I went to visit the communities with a community health worker and those without. The difference is out of this world. With the community health worker and the organized community mobilization for community health services, you find a neat community. The grass is cut nicely. There are toilets. There is no mess. They are clean. So there is a general improvement of community life, in addition to the individual well-being in health. So there is, and then you go to a community where there is no community health worker, and you find the issue problem of overgrown grass and stagnant water and mosquitoes and the issue of things. So really, there is a world of difference.
All right. And Margaret, now that you have such a huge responsibility, which you're doing on voluntary basis, you and many others, what tools do you have available to you to ensure that you do your work?
The tools. The tools which we have is, let's say, like family planning. We are given those drugs. We go and
distribute them.
Yeah, in the community. We have those booklets for referrals and writing down any information on those books. But of late, we are turning to technology. That AMREF is training us on how to use mobile phones, so we are collecting data through the mobile phones. And sometimes we are given home-based kit, which was brought by AMREF before, to treat minor illnesses in the community. We also do screening of NCDs, hypertension, which we are given the machines.
And all these are from AMREF. Do you get any support from the government?
AMREF. They are from AMREF.
Do you get any support from the government?
Yes, we get supervision from CHOOS.
Okay.
Yeah, they show us what to do sometimes. Yeah.
All right, Professor, as we wind up, what you possibly would see as tools that are required by them, other than just remuneration, because I think we've talked about remuneration for a while, but other things that maybe they would require for them to be more effective?
Well, they might require a traveling kit, with the basic first aid supplies that they would help to do first aid things like, for instance, give women sterile equipment so that if they are cutting the umbilical cord, if the child is born in the home and there is someone cutting the umbilical cord, they use sterile activities, they use sterile apparatus and so on. And but the equipment, if I may say so, is secondary to the process.
To the process. The
process of empowering people and raising awareness and changing the community norms. Fortunately, in this country, every county has a community health service element. So it isn't like we are working on zero. There is some roots, there is some seed in every county. But we are only 55%. When Ethiopia is 95%. When Rwanda is 100%, when Sierra Leone is becoming 80%, why should Kenya, which is one of the leading countries, be only 55%? So I think we are really in a position, if we realize that that is the way to reduce the disease burden, and also to reduce the budget on health, because we shall reduce the budget on disease. When you stop, for every investment in a community health worker's work, $1 produces $10 worth of goods, because you stop buying medicines for diarrhea, for malaria, for this and for that, because of all those are prevention. So it is really a way to contain the cost of health care, not on focusing on hospitals, but on focusing on keeping a healthy population.
Yes. All right, I'll need your closing comments. Margaret, your closing wrapping thoughts and possibly way forward.
Okay. I'll repeat again. Community health workers are very important in the community. They have that bonding with the community members. So please, recognize their work. The government and all the stakeholders, recognize what we are doing and pay us so that we can be motivated and continue helping the community. Thank you.
All right, your closing comments, Prof.
Well, I think that I'll just support what Margaret has just said. Let us pay them, include them in the official health workforce list, pay them so that they can have the dignity of living like workers, not as she said, begging from relatives and begging from people, and sometimes, unfortunately, doing what we consider illegal or immoral just to make them get by. Because I think that we should appreciate everybody's effort towards development. And since Kenya has declared UHC as one of the four, the big four, the president has declared, let us not derail it by focusing on a package of supplies, go to the hospital, and then getting nothing there. People are complaining, we have gone to the hospital, but we get nothing there. Let us focus on the community to support the work that Margaret and her colleagues are doing under the supervision and the guidance of technical people so that we improve the health status of this country. It is my hope and my prayer that I will see that in my lifetime.
Thank you very much, Professor Miriam Were and Margaret Kilonzo, who's a community health volunteer in Kenya. Thank you for joining us this morning and highlighting the necessity of having community health workers in ensuring that as a country we end up achieving universal health coverage as envisaged by the Jubilee government. It's now 12 minutes to 9. It's time for me to sign off and say goodbye. And thank you for watching Morning Express. But do stay with us right here on